Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Hello, everyone, and welcome to today's session as a Can COVID speaker series. Delighted to have everyone here and delighted to have our guest speaker here, Dr. Janice Keefe, who is joining us from Nova Scotia. And Janice is the professor and chair at the Department of Family Studies and Gerontology at Mount St. Vincent University in Nova Scotia. She's director for the Nova Scotia Centre on Aging, and she's the Lena Isabel Godfrey Chair in Gerontology and a research scientist at the Maritime Spore Unit. And her title is Family and Staff Perspectives on Implementing Visitation Programs in Nursing Homes During COVID-19 Restrictions. So welcome, Janice. And just to let everyone know, please use the chat function to post your questions throughout the talk, and we'll come back to them at about 3:20 when we have time for Q&A. So with that, I will turn it over to you.
Great, thanks very much, Susan. It's a pleasure to be here and be a speaker on your platform. Yes, I am going to talk about family and staff perspectives on family visitation. Certainly, we know that there have been, oh, my clicker isn't working here. Just one sec. There we go. Just to give you an outline of today's presentation, I want to share with you what we did, why we did it. Actually, I think you probably know that with the lockdown and the COVID-19 pandemic, families were not allowed to visit for 3 or 4 months and had some devastating consequences. So this was an examination of how family visitation programs were implemented in 2 provinces, in Prince Edward Island and Nova Scotia. So I'll share the experiences from the interviews that we did with family and direct care staff, as well as the implementation staff, some of the key messages and what we would recommend coming out of that, as well as what we see are some of the implications beyond COVID-19 and some of the ways that we've tried to get that information out to the public. So a quick overview of our methods. Obviously, with the pandemic, we were on either video interviews or phone interviews between April 2021 and August 2021. This was funded by the Healthcare Excellence Canada through support from the Canadian Institute of Health Research and the Institute of Aging. In total, we had 24 what we call designated caregivers, as well as doing a time to follow-up study interview with them in August. We had 15 non-designated caregivers, so those are individuals what often are called visitors in facilities. 32 implementation staff, 22 direct staff, etc. We also did facility profile surveys. So there were 6 facilities that participated in the study. There were 2 from Prince Edward Island and 4 from Nova Scotia. In addition, we had implementation documents, 97, that we reviewed. And then to get a perspective from outside this region, we had key informant interviews from British Columbia, the UK, and Netherlands. I'm focusing on the family and staff today, but I'll bring in a little bit of the key informant interviews. This is a very messy slide, but it's really just to show you that the evolution of these policies varied over time, and even right now in with the Omicron variant, in fact, Prince Edward Island has had outbreaks, and they didn't have during our study period, the homes in our study. So that's a really important contextual piece. If you're coming from Ontario and Quebec, Alberta, you know that we didn't have the massive outbreaks that were happening in other places, although we still had the lockdowns and we still needed to have the family visitation. One exception in April, May of 2021 was one facility in Halifax. It was very large and had up to 51 deaths. But generally, during the time that we did our study, there were very few deaths in long-term care. So I'm going to jump right into some of the experiences that we learned from the family, and then I'll talk a little bit about the staff and then some of them together. And I hope from your perspective, if you have some questions or you have your own experiences, I'd be really happy to hear those at the end of the presentation or put them in the chat. So certainly from the family perspective, there was a lot of gratitude that was expressed, even though the implementation process caused a lot of frustration. So often we heard, you know, I just would have done anything they said so long I could get in there and be with him. So there was this sort of gratefulness after being locked out for so long that they were finally able to get access. And so that was a little bit of an important perspective in terms of how they were answering questions. They didn't want to cause any difficulties in their access. There was some issues around relationships. They felt that some of the restrictions that were part of this visitation process were quite painful, that eliminated the joy that used to be in long-term care. And so they felt often that the restrictions, they were too restrictive, they were awkward. Sometimes it was very uncomfortable. So there was all of these protocols to go through, and the sort of familiarity and relationships rapport they had with staff were lost. So they notice staff don't have time to sit and talk with the residents or say, hi, how you doing, like they used to. And as one family member said, there's just no joy there anymore. From the staff perspective, on the implementation experience, they expressed frustration with the top-down process. So the directives were externally driven by provincial governments and the chief health officers in those provinces. The facility and the staff had to support this visitation, but there was really very little evidence on the best way to implement the directive that they would have. So usually they felt that they had more flexibility when they had a policy come down from the top, but this one was very restrictive. There was also a lot of time constraints and pace of change. So things changed from week to week depending on the virus, and that made it very difficult to engage other staff members like the direct care staff, the continuing care assistants, or care aides, and the family in the implementation process. The other real problem we heard everywhere, we heard in the UK, was that the government would make the announcement and the families heard at the same time as the facility. And so there was very little opportunity to get the operationalization of the programs changed before the families were looking for that change. So as one staff member said, we're always trying to play catch up from the press conference, because press conference comes out on Friday and it's going to start on Monday, and there the staff had to get everything together and the family were hoping to have the policy in place. Implementing this staff, these directives were quite complex. There's a lot of issues of that balance of safety and flexibility on how and when families could visit. There was also need to have available an additional resources, and that really helped to facilitate the implementation, or could make it a challenge, particularly around spacing in terms of distancing, 6 feet, etc. How many visitors you could have. In Nova Scotia, there was some extra funding provided by the government for long-term care assistance, and you can see they were called the superstars of the program, and they really helped to make it happen. Both family and staff saw communication as key to successful implementation. It was a facilitator when it was clear from the family's perspective. Email was most common, and that seemed to work well with them. But they like to have someone to speak with in person as well. Lots of increase in use of technology as well to communicate. Some complained, though, that facilitation or that communication were too general. They wanted more specificity in what was being presented, and they didn't always have access to the staff. From the staff perspective, they felt that managers and the management provided very good communication, and they did a lot of communication with the families via phone, email, or message boards. They had a lot of frequent meetings with each other in the staff. The challenge became when it was a last minute communication, and sometimes then the miscommunication of the rules led to confusion. So what would happen is sometimes there was the issue of one staff member not really understanding the communication that was that the new directive, and then they would end up creating problems down the road. Flexibility, though, was really key to successful implementation. Families really did suggest that they needed more flexibility in the family visitation programs. It was very challenging in some provinces where they had large families and they were initially only allowed to have one designated caregiver. So that caused some, and then later it was 2, and then eventually 3 in both provinces. But these often had challenges if there were large groups that tend to be gendered. So it was, you know, the sister who was, or the daughter who was chosen to be the designated caregiver. Working families also had some disadvantages because the visiting hours were often during the day, and so getting access after hours wasn't all that easy. There was some issues definitely for residents with dementia, understanding what was happening throughout the process. There was their capacity to communicate in some cases was curtailed, as well as the difficulty in staying in one room. So sometimes when you visit in the room, but the person wanted to wander, but the rule was that the family weren't allowed to leave the residence room. So all of these things contributed to really needing more flexibility. And as well, there's the end of life desperate need for flexibility and allowances here so that more people would be able to be part of the end of life experience, and they needed to be able to have more privacy in that area. So in terms of implementation, you can see overall a lot of the enablers for staff were things like organizational culture. When there was support from manager, when there was teamwork, it all worked well. For the most part in these facilities, the staff had fairly high buy-in and were very excited about the process and the communication. For family, you know, they needed to be able to have that opportunity to get into the facility. Actually, this is an error in my slide, but I'll just tell you that there was these enablers that allowed family to reach out to be able to get access to their relative and be able to eventually go outside with them, etc. Lots of barriers, though. Last minute was always a problem because it left staff confused, and then it provided families with misinformation, etc. And sometimes there was that negative interaction with staff because they had to be reminded of the rules. So what was the impact then of these family caregiver family visitation programs on the administrators? From the key informant interviews, we found that administrators were often the point of contact when there was upset among family members, and they had huge challenges around managing the family's expectations and their desire to have up-to-date information about their resident really frequently because of their anxiety that they were experiencing. They also had to deal with additional workload challenges. As we all know, there's a shortage of staff in long-term care. When we had so these increased mental health issues among the staff. So it wasn't just where they were working, it was also the staff's challenges at home, having to, homeschool children, having a partner who may have lost their job. So all of these anxieties, work-life issues, the fear of the unknown, the fear of bringing in COVID to the facility, the fear of taking it home. And so there's all of these factors that really it had a great deal of stress on administrators. And I really like this quote in terms of just identifying from an administrator's point of view how they were feeling, and the idea that being able to welcome families back on site really helped them to see us as humans instead of an institution. And she uses the analogy that in the meeting, when people who started the meeting wanting to put me on a crucifix left me with a hug, not a real hug, but a virtual hug in a way. So there was that, understanding that they were real people trying to do the best they could in a difficult situation. Family reintegration had a lot of positive impact from the staff perspective. They noticed that the residents were doing well, that the families were able to provide this instrumental and emotional support that was really lacking. They did have additional workload challenges, the need to expand their scope of work around sanitizing, scheduling, training family members, managing, of course, family expectations, etc. And this, as one staff member said, and I'll just focus on the end, the work goes a lot smoother when no one is in, but it's better for the residents to have family in place. So I think that's where they were coming from for sure. What was the impact on residents? Of course, the residents, their whole mental health and overall well-being improved. So prior to the visitation program, there was a noticeable decline in communication, in cognitive decline, stopped disruptions in eating patterns, and visitation seemed to improve their communication, their alertness. And I love this quote from one of the family member. His eyes lights up and he has a twinkle when she first returned. She said it was like he was a ghost. His personality has returned and his mood is much better. So that's, just a reflection on how residents improved after the visitation program. There was, of course, mutual benefit for the families and the support person, that they had that sense of routine. If the resident is happier, they're happier, less anxious. They certainly appreciated being able to spend time with their family member, particularly if they had dementia, because they felt if it went on any longer that the person may not continue to recognize them. So what are some of the long-term implications beyond COVID? We need to definitely understand that family are the essential partners in care, and recognize the critical role that they play in the daily care and lives of their residents. In the future, or in future outbreaks such as influenza, we feel that we don't need to lock down facilities from families, that both family and participants think that these visitation programs can actually work in future outbreaks. So they talked a lot about having a blueprint that they could put in place. We really tried as well to get the message out, to include our administrators. So as part of our project, we had the 6 administrators of each of the facilities participate in team meetings and individual meetings where we would share the results with them and get their feedback. We also included 4 family caregivers who helped us with training some of the our research assistants in asking the questions and what some of the experiences of families might be. Once we had our findings, we had a webinar with all long-term care homes and government, Nova Scotia Health Authority, PI Health Authority, policymakers. in the two provinces, and this is available on YouTube. I can put this in the chat box later. We've also tried to get to different academic conferences and invited speakers, the International COVID Today's presentation, a number of presentations at the Canadian Association for Health Sciences and Policy Research, the Canadian Gerontology Association, the Gerontological Society of America. So we're really trying to get better understanding of family visitation out there. We've also done some practice briefs for the home. So briefs that are looking at family visitation, and in particular, I don't know if you can see this, it's just some clear messages so that they can understand perhaps some practice considerations. How to communicate can be a barrier or an enabler to implementation. These kinds of just basic informations that perhaps we all know, but maybe we forget in the midst of our day-to-day work. And so we have one already on communication, one on what we learned about the impact of family visitation policy on residents, family, and staff. So we feel that we're not only trying to get it out broadly, but also trying to get it directed to the people who can actually put it in place. So I'm going to stop. I just wanted to, yes, I do want to report that we also have partnered in a similar project with Healthcare Excellence Canada, where we looked at facility or care facilities best practices of including family in their facility. And this report you can download from Healthcare Excellence. You can also look at the summary of their webinar that we held with them. And then finally, I want to say that I participated on the National Standards Committee for Long-Term Care from HSO, the Health Standards Organization. So I would encourage you, if the audience, if you're interested, to look for these national standards are now out for public review. And so we would like to have people, some of the findings help to inform those standards, but we'd really like to have people from the public really look at them and provide us with some feedback, so we can have much better standards for all facilities, all provinces in the area of long-term care, to really value the quality of life of the resident. So I'm going to end there. And these are some of my other co-authors, as well as a number of research assistants, family advisory groups, the administrators, and so on. Thank you.
That's terrific. Thank you so much, Dr. Keefe. We have some questions here, but I wonder if I could start with, and it might be in your practice briefs, which are fantastic, but were there any sort of innovative practices that came out of the visitation programs in terms of, the way space was laid out, or the way families were brought in or exited? I'm curious about the kind of really pragmatic changes that might have been made.
And so in one of the facilities, there was the ability to train the family member to do their own screening, and they were because the facility, and again this comes back to the physical design, because the facility was in different pods, they actually had a separate entrance. So rather than having everyone go through the main door, they actually were able to have sort of clusters of families in one area, so you weren't as exposed to those situations. There was also this whole change around the staff. Maybe it's not so innovative, but really bringing recreation when you could no longer have recreation, having them help with some of the screening and helping individuals to understand the whole process. I think that became really important. I know that in our report to Healthcare Excellence, there was also some other approaches from the facilities to ensure that like families may they would hire families to work in the facility so that they could get access and help with the staffing situation, but also be able to visit with the relatives in the facility. So there was, people tried in different ways to circumvent some of the challenges of the system, for sure.
Great, thanks. So I'll turn to the questions now. First is, what health communication strategies were used by government, public health units, or nursing homes to communicate and enforce visitation program guidelines?
Sorry, I didn't quite hear you. What health communication strategies?
Were there
I'm
specific
sorry. Yeah.
strategies? Yeah.
Okay. Yeah, I see it now on the chat. Yeah. So that's a great question. So there were a lot of variation, I would say, and some of it depended on resources and also on whether some of it depended on the leadership. Like, was the leadership of the facility thinking ahead about how they might be able to do this, or were they waiting for the directive? So you know, they embraced Zoom calls with the families. They would hold regular meetings so that people could have their questions answered and they could share information all at once. They did a lot of communication through FaceTime clusters with their family. Some actually would call individual family members because they weren't technologically advanced. So they did try different strategies, like a phone call, to make sure that that they understood what was happening. What else did they do in terms of visitation guidelines? One of the things we did understand, so the designated caregiver, and this became a problem with large families too. So the designated caregiver, there's like one point of contact. And so they had to make sure that everyone else in the family, in the network, were informed of what was happening with the guidelines. So that can be a barrier. We heard from some of the non-designated caregivers that they never really knew when they could go on, or when they could go in, or when they couldn't, because of some breakdown in communication. So really important communication strategies from the homes, and that was our main focus. We didn't really examine we learned about what the government did and the public health measures and how it impacted on the home, but our primarily focus was on the implementation of the program from the facility perspective and from the families and staff in the facility.
Great, thanks. Next question is really around the evidence about limiting visits from family members, and whether and to what extent they reduce the spread of long-term care facility infections. And the reason this person asks is that there appears to be the key reason that governments keep using visitor bans as a policy tool.
Yeah, this is a great question. And I have to say, some of our key informant interviews, particularly the one I recall in the Netherlands, they have a group that it's a research group that are in facilities, were in facilities previously. They have a research center. And what they were able to do was actually do a case study of homes that were restrictive in terms of families and homes that were more open in terms of family access to residents. And when they looked at the outcomes from that, they found no difference in the incidence of the virus for the residents. And I think one of the things that a lot of the families said to us, if you are allowing staff to go in, especially during times when there weren't having to be tested, if you're allowing staff to come in, don't you think that family members don't want to bring COVID into the facility? I mean, they had this idea that they were the ones that were going to be the most risk averse. And it is interesting, and this was in the two provinces where there wasn't a lot of outbreak. So there was a bit of frustration from that perspective for sure.
I'm going to actually just take a couple of the rapid fire ones. So when was the study conducted?
Yeah, so this study was between April 2021 and August 2021. So that makes a big difference, because right now that we're actually trying to figure out if we can go into the facility, or not the facilities, but reconnect with the family, because in these two provinces, the Omicron is actually, as I said in the beginning, there's more exposures for sure.
Mm-hmm. And the other one was just about how to get a copy of the PDFs. Is there a website they can?
Yeah, so I can put in. I know I had the PowerPoints on my screen. I can put my PowerPoint in a PDF. It's available on Nova Scotia Centre on Aging, or it will be. But I can also put some of the reports in the chat box if people would like that.
That's
no
great.
problem.
We could also share the PDF of your presentation if you're willing. You can change it if you like.
Yes, I just, slide 10, I obviously have not the latest version of my presentation. Don't you hate when that happens? Yes, because I was just copying and pasting. And I know I filled it in, but not on this version. So I'll just correct that for you, Susan, before you send it out. That would be great.
Yeah, and then we can post the recording and along with your slides, which is fantastic. Thank you.
I would just like to say, I think some of the questions around safety and relationality, that is such a fundamental concern in this area. How do you keep people safe, but also not totally destroy their quality of life?
Mm-hmm.
Yeah,
that's great. And I'm just going to take last question here. I'll combine a couple. Is really about sort of the caregiver and family voice. One asks whether or not you think the government is listening to the voices of family members, and another is, should nursing home residents be part of future conversations on visitation programs? So, just your thoughts about engagement.
Well, yeah. Yes, and yes. I think now that we have a little bit more time and space, and we're perhaps better positioned or better understand the pandemic, the virus, and the spread, I think it's really important to engage family. And also to ask residents how they felt about the family program. And that's part of, pushing the national standards, public, wanting the public to get involved in looking at those national standards, because we need people to see what we're trying to achieve. We need to understand from residents and families' perspectives, what went right and what went wrong, and how can we improve that relationship so that people are still able to engage and be supportive of the residents in the facility.
That's great. I think we'll end it there. A couple of people have posted resources in the chat there.
Great.
So people can note those, and I think the last question will be answered on your slides, actually. So thank you so much, Dr. Keefe. It's just been terrific. Congratulations on this study and all the others that you're working on. So fabulous work and very informative. And thanks everyone for joining us. Just to let you know that next week our talk will be from a research team at Sick Kids in Toronto about the impact of the public health measures on children. So great. Thanks everyone.
Thank you. Take care.
Yes, I appreciate it.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCovid or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.